The adrenal medulla is responsible for catecholamine production. Because we've already covered this in the autonomic nervous system section of pharmacology, we won't discuss it here. There is one thing I want to mention, however, with respect to the adrenal medulla. I want to talk about a cancer or a lesion called pheochromocytoma. Pheochromocytoma is a neuroendocrine tumor. It is often found in the adrenal gland, but it can be found outside the adrenal gland as well. It results in excess production of catecholamines, mostly norepinephrine. We can do all kinds of tests. One of the most easy and simple tests is a 24-hour metanephrine test of the urine. We check for vandinal malonic acid and metanephrines as a routine in a 24-hour test, but we can also do clinical testing and take a look at patients' blood pressure and heart rate and see that they tend to have very high levels. Serum testing can also be done. It is exceedingly expensive, but it's highly accurate. I rarely have done serum testing on patients when I'm diagnosing pheochromocytoma. We've actually made the diagnosis just with the 24-hour urine and clinically, and we've actually managed to remove successfully many pheochromocytomas. Remember that plasma metanephrines can also be analyzed. We would be looking specifically for normetanephrine and metanephrine. Treatment of pheochromocytoma is invariably surgical. We have to remove the tumor. Now, there are some pharmacological treatments that we do utilize. These are not permanent treatment therapies. These are just holdover treatment therapies or bridge therapies. Phenoxybenzamine, we've learned about this drug in the CNS lectures, is a non-specific irreversible alpha blocker. A short-acting alpha blocker is prazosin. We can also use terazosin as well. Now, the other thing that we like to use is labetalol, which has combined alpha and beta blocker activity to help us control the heart rate. It's important that we never use a specific beta-1 blocker because when you give a beta-1 blocker to a patient with pheo, you're going to have unopposed alpha activity. And for the purposes of the exam, we're going to always say never use a specific beta-1 blocker. In reality, sometimes we have, but I won't get into why, and I want you to forget what I just said. On your exam, never use a beta-1 blocker. Remember that part. Now, in terms of volume repletion, remember that you want to give these patients fluids, and sometimes we actually do something called salt loading in some patients. That's a specific issue that we deal with in the preoperative clinic.